Hi, my name's Ellen Heron, like Robin said, and today's presentation is going to be on maximizing the potential of your AlignRT system. So we'll go over case studies on challenging and uncommon setups. I am a senior therapist at Northside Hospital Cancer Institute here in Atlanta. I'm actually at a satellite facility about 30 minutes north of here, and we are one of 6 centers in the Cancer Institute system. So Northside Hospital does receive payment from AlignRT as a center of excellence. And before we get started, I just wanted to give you all some background of our workflow and how our clinic is, just so you can keep that in mind when we go over these case studies. We are a one-machine clinic. We have a TrueBeam linear accelerator. We've been using AlignRT for 4 years, and within the past year, we've just recently transitioned into markless setups for all of our patients. Most of our patients are in 10-minute time slots, and I think currently we're treating about 32 patients. So from our experience with AlignRT, we've learned it provides detailed and easily accessible information that simplifies patient setup. It also provides the capability to monitor the patient through treatment and is beneficial in helping with challenging setups. We've also learned it decreases setup time and repeat imaging on challenging setups by detecting that necessary movement with more precision and accuracy than traditional setup methods. So some of the objectives for today, we'll review case studies for patients with unusual treatment positions. We'll replicate initial patient position while recreating a new immobilization device. Discuss the pros and cons for use on electron fields. We'll address the benefits of using AlignRT for extremity patients and discuss the use of AlignRT as a replacement for marks in areas where marks cannot be retained. So this first case study is on a head and neck patient. This is not your typical head and neck patient. This is an 81-year-old male. He presented with stage 4 head and neck cancer. This particular patient was unable to lay in the supine position due to a painful hernia on his left flank. So this was actually done at a different center. They used a face mask and then rotated his left shoulder up so he wasn't laying on that hernia. And back lock was used under his shoulders. We currently have clear vision mask now. Like I said, this one was done at a different center. They used the old mask. And because of that, we used his shoulders as our primary ROI, since that was the trickiest part of the setup anyway. So as you can see, here's an example of our ROI. We encompass that shoulder and the top of the arm, and then a stable portion of the chest, excluding the armpit fold. So most importantly, this patient received 33 accurate treatments in a comfortable setup position. The patient was deemed unreproducible on the original machine without AlignRT. I think it took multiple cone beams and the patient on the table for too long of a time, so they just got him down. So with the AlignRT system, it helped us to achieve that correct shoulder position before even leaving the room, which helped us minimize repeat cone beams, and this patient had minimal daily shifts. So just below you can see a picture of actually how rotated this patient was and what we had to reproduce every day. And this next case study is on Ledderhose disease and Dupuytren's contracture. Ledderhose disease is actually not cancer. It's a contracture of tendons in the foot area, and then the Dupuytren's is contracture in the palm area. So this was a 58-year-old female presenting with a nodule in her left arch. And for these treatments, they require electron beam treatment for 5 treatments and then come back 12 weeks later for another 5 treatments. As we know, the foot would be a difficult area to maintain any type of marks, so this was a great candidate to use AlignRT on. Here you see this patient's in the prone position. on reverse commie fix, and what we've learned using AlignRT, as far as immobilization, sometimes less is more. As long as that patient can stay in a stable position, you don't want to immobilize too much where you're covering where it could block the cameras or your ROI. So this is an example of our ROI. It extends over the heel and then down each side and then almost to the toe region. So we use AlignRT for daily setup, avoiding any type of marking. And like I said, the great thing about this, for this disease, since they return 12 weeks later, is that AlignRT stores that position in the computer. No marks or no verification has to be done when they come back in for their second round in 12 weeks. So this next case is on a prone pelvis, and this is not our typical pelvis patient either. This patient presented with an extruding rectal mass. She was unable to lay in the supine position and actually unable to lay flat in the prone position. So with AlignRT, we've gained confidence to make our setups more comfortable for the patient, knowing that they're reproducible. So we elevated her pelvis up, and cushions were placed underneath her. So she's prone on the prone pillow, back lock, and cushion under her pelvis. And then this is just an example of her ROI. We extended it across the buttocks region, down her hips, and down her thigh, and then excluded her rectal mass. So this patient, most importantly, was treated comfortable for all her patients. Her treatments. Her shifts were minimal and repeat imaging was minimized. The next one's on a prone breast, and I'll start by saying we are no experts on prone breast. This was our first prone breast case. I know we have more coming up, and we have learned a lot from just this one case. We've learned to scan your patients before at CT to see if they can even maintain this position. And in this case, this patient was 70-something years old and had arthritis, and it was painful for her to lay in this position for over 10 minutes. So eventually this patient was actually rescanned in the supine position to complete her treatment. However, we did do a verification on her and it went well, so I can talk on that. We'll see if this technique works on the ones we have coming up. So here she is. We have a Q-fix prone breastboard. She's prone on the breastboard with the left breast exposed. As far as her ROI goes, I know there's different ways people set these prone breasts up. I know some people do a setup field, which is 10 cm below the ISO. To keep things consistent in our clinic, we decided to set it up like we do every other patient, just to see if it would work. So that's what we did here, and it did work. So we included her affected breast in the ROI and then extended it up to about mid-back and then extended it to her head to capture some of that arm or shoulder. So we set up to DICOM the same as you would a supine breast. Our largest shift on the verification day was 0.3 cm, and then no manual adjustment was needed of the breast after aligning to that DICOM image. And all in all, I think this verification took us 20 minutes. So the next case is on extremity patients. This is a patient who presented with a large B-cell lymphoma to both arms and legs. The patient's treatment consisted of 4 different ISO centers to be treated using partial arcs. And then on top of that, all fields were planned with 1 cm bolus covering the entire field. So just so you can see how our setup went, this first one is of his arms. Once again, we minimized the mobilization so we wouldn't block out that area where we wanted our ROI. So you see his arm is completely exposed. And then same thing for the leg. It's open where we're treating. His foot is in a foot holder and his knee on a knee sponge. So these are just example ROIs for his arm. We extended it from the wrist to the elbow and his legs from the ankle to the knee. For this particular patient, because there were 4 ISOs, you would not want to cone beam them every day. That would be a lot of dose. So with AlignRT, we reduced it to kV daily. And his treatment went so well, his setup went so well, that if it were not for the bolus, which we used Superflab, and it actually wrapped around the sides of his arms and legs and the top, but if it weren't for us having to place that, then the patient could have been reduced to weekly imaging. His shifts were very minimal. So his daily treatment time per ISO averaged to be less than 10 minutes. Minimal immobilization was required and shifts were minimal. So this next one's on electron treatment, and electrons are a fairly simple and straightforward setup anyways, and pretty quick. So you can kind of decide within your center if you think that's AlignRT is the better route to go for that. But whatever you decide, this case was a patient who presented with open skin. It would be impossible to keep marks on her, and not to mention the risk of infection from doing that. So she was a great candidate for AlignRT. We drew her ROI across her whole chest and then removed some of the bulky area that we thought could scab over or change during her treatment. So no marks were needed. We used stable borders around the open skin for our ROI. And I will say these electrons, a lot of times if they're a smaller cone, you have to set them up before you put the cone on. And then put the cone on, and sometimes the cone blocks it. It just depends on your gantry angle and SSD. Sometimes with the larger cones, we found out like the 20 cone, it can actually read through it. Or if your SSD is 110, it can still read that treatment field. Or the other option is to move if you want to monitor through treatment, you can move your ROI so the cameras can read it. So this next one is a change of external anatomy. This patient was a patient whose implant dropped. She was treated for 13 fractions using DIBH protocol. She could no longer achieve treatment position using her reference image. So when something goes wrong, it's always good to go back to your DICOM image. She could no longer reproduce that. So the patient was CT'd and her expanders had shifted dramatically, so she was then resimulated. But without AlignRT, it might not have been caught till her next set of port films. So this next section's on replicating devices using DICOM reference image. And I will say this is not necessarily a protocol for our department. This is something the more comfortable we got using AlignRT, we decided to think out of the box with it and see how it could help us. And we tried this out on a few patients and it worked. So maybe one day we can make a protocol out of it. We'll see. So using the initial body contour from CT, AlignRT offers an innovative and effective option to replicate an immobilization device that has malfunctioned or been displaced. Accurately replicating these devices eliminates the need for the patient to receive additional radiation encountered by a new CT scan and avoids delaying their treatment. The physician, dosimetry, and physics team benefit from this time-saving approach by eliminating the need to duplicate their work on a new plan. So for this first one, this was a patient who is in mid-course of treatment to his prostate and his vac lock deflated. A new vac lock was made in the treatment room by setting the patient up to their DICOM image. So we had a vac lock that the air was in, laid it flat on the treatment table, and then achieved his DICOM position. Once we achieved that position, we sucked the air out of the vac lock and wrapped it around his legs. And then we made sure while we were doing that, we maintained that DICOM position. After his vac lock was made, we then cone beamed him, as he is daily, to verify his position. And so this is just images of how we set up our leg back locks. They're from about mid-thigh to the feet, and then their buttocks is actually flat on the table. So from his cone beam, his shifts were minimal, and the shifts that he did have were primarily due to internal marker matching. All of these treatments that we did like this were approved by the doctor before treating, and cone beam. So the doctor approved this imaging and the patient position, and then the treatment was continued without any delay and no extra work was needed. This next one's similar. This was a breast case. The patient was mid-course through treatment to her left breast. Her vac lock deflated completely again. A new vac lock was made in the same way in the treatment room by setting up to the patient's AlignRT DICOM image. And same thing for her. We placed the vac lock under her. She laid down on it, got her in that DICOM position. When she was in that position, we formed the vac lock back around her. And then we don't typically cone beam our breasts, but in this instance we did to confirm correct positioning. So this is just a picture of how our breasts are set up. You see the vac locks under the arms on the breastboard. And once again, her shifts were minimal. The doctor approved imaging and the patient position, and then treatment was continued without any delay and no extra work was needed. The only extra thing done for her was a cone beam CT that day. And then the last one is a face mask. This patient was a brain patient who was admitted as an inpatient. She went downhill quickly and made the decision to go to hospice. So her chart was closed out and the mask thrown away. Somehow the patient miraculously improved and decided to resume her treatment. So you can imagine our face when we were told that and just threw the mask out. But same thing here. In order to avoid delay or rescanning the patient, we tried the same technique. So we had her come in the treatment room and she laid on the S-frame as she normally would on her headrest, pulled up the DICOM image and set the patient up to that. And once again, we have the open face mask, so we're setting up to that open area. When we achieved that position, a new mask was made. And then when we made it and when it was drying, we made sure to maintain that correct DICOM position and adjust it if needed. Cone beam was obtained and accompanied by physician and dosimetry approval. So for her, the largest shift from cone beam was 0.2 cm. So the patient received treatment that day without any delay. Without AlignRT, this patient would have required a new CT, causing delay in treatment and unnecessary radiation from that CT. Not only does it benefit the patient, it saved the entire team involved in the patient's treatment from having to repeat their work. So in conclusion, AlignRT is a beneficial tool for familiar setups and is proving to be even more beneficial with unusual setups that require longer setup time and repeat imaging to reach that desired result. Additionally, the AlignRT DICOM image can be used in the treatment room as an effective means to recreate immobilization when validated by cone beam CT and physician approval. That's it.